3:02, we'll go ahead and get started. I do see people start putting their organization names next to their Zoom names. That's awesome. I see Amy, Asha, perfect. Art, Davidson, great. Okay, and thank you, Jeanette, for saying hello in the chat. As a friendly reminder, we are recording today's session, and it will be posted on our Confluence site within 2 business days for everyone's review and reference. Great, yep, some more people joining us. Please feel free to continue to say hello via the chat. All right. I have 3:02 on my end, so we'll go ahead and get started. Again, thank you all for joining us on the Social Determinants of Health Data Exchange for Chronic Disease Prevention Initiative. Today is our workgroup meeting number 8. We'll do a final review of the feedback received on the use case package, as well as launch the consensus voting process as a team together. Here is our some housekeeping remarks. Everyone has been muted to prevent background noise. We encourage participation throughout the call. You have the Zoom chat featured at the bottom of your Zoom meeting window, where, if you don't mind, please ensuring that you send chats to everyone so we get to see them. We also encourage the use of the reactions feature. There is a virtual raise hand icon there. If you would like to speak live or share any comments, questions live with us, that will be a good way for us to triage, participation. And if you have any technical issues, we do have Sarah Behol behind the scenes supporting as a Zoom host for today. Looking into today's agenda, we'll start with some welcoming remarks. We're very grateful for today's guest speaker. You'll hear more about the USCDI Plus initiative, and then we'll dive into the summary of use case package feedback received, and we will launch consensus voting, review recap the instructions, and review our next steps together. And then we do have some work group closing remarks. So for some of you that have been with us from the beginning, we have gone through a journey. We started back in April, and we are now about to conclude the series of calls. Sorry about that. So we are here on July 27, and as mentioned, we have a very interactive agenda for today's call. And we, as an outcome of today's meeting, we kindly ask all committee members to submit their vote on the use cases that have been developed through this process. The consensus voting period opens today, and it concludes on August 3rd. So zooming in a little bit on today's objectives, we will share and discuss the feedback that we received on the package that we share on July 13. Thank you all for those that were able to send feedback. We did get great comments, and we made some revisions. We will launch the consensus voting process, which is the due process to finalize this work group deliverable. And we will, again, reemphasize that the voting period opens today and will close on September 3rd. We will go over some details throughout the call. And just to ground us into, a little bit of the background, so clarifying in scope, this initiative has convened a multi-partner group of stakeholders, and our scope has been, public health use cases for chronic disease prevention. We do have, we created and posted a work group charter where indicates that through this consensus-based approach, the work group has been convened and collaborated with industry experts to really identify a business case and a set of high priority use cases to support chronic disease prevention and health promotion. And this is a reminder on the out of scope elements for some of you that may be new to the group, and we will put in the chat the link to the work group chatter as well. background on the initiative. So as you're familiar with the Gravity Project, they developed 3 use cases, primarily from the clinical perspective. So they really focus on the functionality and interoperability required to allow an end user to document, retrieve, and send, exchange aggregated coded social risk data. Here it's an overview of the use cases that have been published through the Gravity Project, documenting social determinants of health data in conjunction with the patient encountered, documenting and tracking related interventions to completion, also known as bidirectional referrals, and gathered and aggregate SDOH data for uses beyond clinical care. And this is really where our work has come in. We have been through this work group, bridging the gap between the clinical care perspective and really bringing in the public health perspective. We have developed 3 public health use cases, showcased here A through C. So the first one, the focus on community health needs assessment, leveraging aggregate data to support the community health needs assessment, and assessment of the state, tribal, local, and territories health department diabetes program, and monitoring federal program success for individual, program, and population health advancement. You may recall this visual that we have used during our work group meetings, which before today to showcase a gap, that there were no public health use cases to support or that were built off right out of this third Gravity use case. And at this point, we are so excited that we have been able to bridge this gap. And here's just a summary visualizing that, visualizing the Gravity Project use cases plus the public health use cases that we have developed. As it relates to the coded terminology, you see that reflected here by the coding stewards for assessment, observation, diagnosis, goal setting, and interventions. And our focus through this work group has really been centered around the public health perspective and being able to make the case of why public health agencies need SDOH data and able to use it across different systems. From a high level timeline, this has been a journey. Prior to launching the work group in April, we did conducted several key partner interviews as part of our information gathering phase. After doing that work, we launched the work group in April, which was a big milestone where all of you joined for the first time, or some of you. In May, we successfully published the public health SDOH business case, which is ready and downloadable through our Confluence site. And now in July, as we are coming close, we have come up with 3 use cases, high priority use cases, and we are ready to launch consensus voting so we can finalize that work group deliverable. And in August, the EMI team will deliver a closeout report to CDC highlighting key findings and some of the feedback received through this process. And moving us right along, I do have Kyla, who will introduce our guest speaker for today.
Thanks, Gabriella. So today we have Neja Garrett from CDC. She will be talking to us about USCDI. USCDI is United States Core Data Interoperability. Just a little bit about Neja. Neja is a senior public health informatics health scientist in CSEL's Public Health Informatics Office, Public Health Data Modernization Advisory Unit. She leads several data modernization initiatives, including FIRE projects. And she's also the co-chair of the Data Standards and Harmonization Workgroup and CDC's HL7 FIRE Community of Practice. She serves as an informatics subject matter expert on data standards and harmonization, clinical decision support, EHRs, and informatics. She has been serving CDC since 1999, providing public health informatics leadership and expertise across CDC and externally. Also, she's a graduate of CDC's Public Health Informatics Fellowship Program. Before I hand it over to Nidra, I just wanted to just mention, as we're thinking through about USCDI, and she's presenting about USCDI and USCDI Plus, I know it is out of scope for this work group as it relates to developing standards and as well as identifying data elements. However, we do see that the work that we're doing in this work group align very well with USCDI and USCDI Plus, particularly USCDI Plus, because it really will help us think through taking the priority use cases that we've developed out of this work group, rather than the data elements that are needed for those use cases. So with that, I will hand it over to Nidra. Thanks.
Good afternoon, everyone. Thank you, Kyla, for the introduction, and thank you for the invitation. I do want to acknowledge my co-chair, who is with your center. Akaki Lekavili is on the phone, I believe, and we are co-chairs of the Data Standards Management Harmonization Work Group, and we've been co-chairing the effort for getting all of the input and evidence on these data elements across CDC programs. So I wanted to acknowledge Akaki. And also, Akaki, if there's something that you would like to add or share during the presentation, please feel free to do so. Next slide, please. So USCDI is really a core set of standardized data elements for health. It basically has these core standardized data that are the floor. You can look at them as a minimum set of data that we would like to have within electronic health records, and it creates a pathway for these data to ultimately one day be part of certified electronic health records. So that's the goal, but we have embarked on this effort with USCDI in the versions 2 and 3, and we have version 4 coming up that will start working with programs in the August timeframe, because those are actually due for submission by September 30th. And we are leading the work around USCDI Plus, which will be really the focus of this particular presentation, just to let you know where we are, what we, the process that we're in, and so forth. So this establishes a baseline of harmonized data elements that can be used very broadly across multiple use cases, including patient care and patient access. And so we are, very happy to be able to put forth those for public health for consideration of those that are in electronic health records. Next slide, please. So with USCDI Plus for public health, we've been working really closely with ONC to lead the public health domain for USCDI Plus. There is a second USCDI Plus initiative for quality measures that's being led by CMS. So we've been leading the charge on this, and USCDI Plus really gives us an opportunity to really look at data elements that are beyond USCDI, and we recognize that there are some limitations with what gets included within USCDI. And so this gives us an opportunity to identify other priority data elements that they're not fully met within USCDI. And we have been engaging with our partners as well and getting input and feedback on many on the data elements that we have gathered from programs. We do meet on a bi-weekly basis, and if any of you on the call are interested in participating, feel free to reach out to me or Akaki or to the dsmh@cdc.gov mailbox, and we will get you added to that. But we realize that there are a lot of different approaches for how state and locals and programs have been collecting very similar data, and those data that are beyond USCDI. USCDI is limited at this point, but the goal would be to expand over time. But we do know that not all of the needs that we have are met by USCDI. So USCDI provides that additional opportunity for us to bring forth those data elements for consideration. And the approach that ONC took on this was to really identify those priority use cases in order to get at the priority data elements. So this is really a start. So I'll go over the use cases that we have been working towards in just a little bit here. Next slide, please. And so just to give you an idea of the process that we've been using internally here to CDC. Again, like I said, we work very closely with ONC and trying to make sure that our processes are aligned with them and that the way in which they will be, vetting and getting that input. So the first thing that we did in terms of the use cases is to identify those data elements that are already available in USCDI version 1, 2, and 3 that we are able to leverage for those use cases. And then secondarily, we looked at those that were submitted but did not get published in the final versions because there was a lot of work that was put into identifying the use cases, the standards, supporting standards, if any of those data elements were included in various technical specifications. So those were quite well documented. And so we wanted to look at any of those that we had submitted as potential for including in any of those use cases. And also looking at any beyond that, that might be available in IGs or message mapping guides. And so we've been compile those data and identify and determine those that we wanted to put forth. And then making sure that we had all the supporting evidence for those and consolidated those and had a review by, the process to have that reviewed by partners. And then we submitted with, within their ONC's on-deck system, the same place that we actually submit those for USCI version 1, 2, 3, and 4 to come. Next slide, please. And so just to give you an idea, we actually identified coordinators for each of the use cases. And as you can see there, you've probably seen these before, but we had use cases around case-based surveillance, lab data exchange, situational awareness, maternal child health, multi-direction exchange with healthcare and other partners. And then the one that most relevant to this particular group is the one on risk behaviors and drivers of inequity, which Kyla and Jen Wills and Nikolai helped to coordinate. Next slide, please. And so just to give you a sense of, the amount of work and the number of data elements that were put forth, as you see with the multi-directional exchange with healthcare and other partners, we had several use cases within that related to bidirectional referrals, e-referrals, related to MINS, community and clinical linkage. And you'll see that there were, those numbers there reflect the number that actually went forth. So at bidirectional, for example, there were 50 data elements that were identified. But then you look at some of the other use cases like case-based surveillance, which you might expect, there were 100 that were identified, which, span everything from the demographic data to some of the laboratory data and so forth. And there were, a few that went forth for maternal child health. And we were able to leverage some of the work that programs are involved in with other agencies, like with maternal child health, with NIH. There's a project that, maternal child health project that was actually looking at some of those data elements that we were able to leverage that work and identify those. And so the intent was to identify data that would be available in electronic health record, but ONC actually did allow us to put forth data that were not necessarily in electronic health records, but we wanted to at least put it on the radar. And, that's something that we can work towards in the future. For example, in situational awareness, there were a lot of those data elements that are not in electronic health records, but we did put forth those anyway. And then with risk behaviors and drivers of inequity, there were 62 that went forth there. And this gives us opportunity to really align our work with what you all are doing in this particular project to, to ensure opportunities for promotion and also to make sure we align and that it's coordinated. Next slide, please. And so in terms of a timeline, so we actually worked with getting these data within ONDAC from July, actually until as most recent as today, getting that data into ONDAC. And so now ONC is actually reviewing those submissions. They are releasing it to limited number of people for review at this point. If you're interested in reviewing, we can pass it along to ONC, but it's not been made publicly available to everyone at this point. So that review is happening, and then they would, do expect to publish these USCDI data elements in the fall. So that's the tentative timeline at this point that we are working with. So I think this is this is the end of my section. I know I only had like 10 minutes, but I do want to see if Akaki, if there's something further you might want to add, or if you all might be interested in some of the particular data elements that went forth within the social determinants of health area. We can show that to you or share it with you later. Akaki, was there anything else that we might want to add here that I may have missed?
No, this was great overview. Thank you, Nidra. Nothing else to add. Looking forward to questions.
Thank you so much, Nidra and Akaki. It's Gabriela with EMI. I do see a question in the chat. Nidra, if it's okay, I'll go ahead and ask it out loud. Sarah's asking, how do we get on the review of the elements again?
We will need to, so if you want to review before they're actually made publicly available, you can send an email to me or Akaki, and we can get that to ONC. But they will be releasing it publicly, the site out publicly, and at that point, anyone can then provide comments. There's space there in the system to provide comments on what's been proposed. But like I said, if you want to have more of a early look and review, they are releasing it to some people early.
Thank you. And another question did come in from Georgia. Is ONC doing any consultation with Thrives on the elements?
Any consultation with, I'm sorry, I didn't hear that.
I think tribal nations on the elements.
Oh, I honestly, I don't know. Akaki, have you heard any in any of our discussions, any mention of?
Not explicitly. I assume they would be, but not explicitly. We could potentially ask them if I know that they have lots of sessions with partners and engagements, but I'm not sure.
Thank you. And something that we can definitely circle back to. Appreciate the question, Georgia. Thank you. And she's just expressing also her saying that she's glad to hear that at least there'll be public comment, and to be more proactive and in specific engagements with tribal nations will be greatly appreciated. Thank you, Nidra and Akaki. Any other questions or comments? Hey, hearing none. Again, on behalf of the work group, we really want to thank you both for your time during today's work group call and for your contact information. We'll ensure to put it as well in the follow-up email with today's recording and slide deck. Thank you so much. We'll transition here. Thank you so much to the remaining items of our agenda today. So I'll hand it over to our experts, Amy and Sheetal.
Good afternoon, everyone. So like we have in previous meetings, we just want to do a very quick review of, sorry, hold it, I just need to flip a screen here. A very quick review of the story. Hopefully after all of these meetings, you're familiar with the story, as familiar with it as we are. And then we're going to provide a little bit of the feedback, a summary of the feedback we received on the use case package and how we plan to address it. So as you can see, and you've seen in every meeting since we've had a set of personas, this is the personas and individuals that we have been working with that are in the public health story. So next slide, please. And again, just very quick, as we've said, the 3 use cases align with the 3 parts of the story. So the first part of the story really focuses on how our county health department that's working on a community health needs assessment leverages aggregated SDOH data from FQHCs and community-based providers going through a regional HIE, and really to look at the burden of food insecurity among people at risk for or with diabetes. The second use case really is focusing on a state health department that is working to prepare its continuing application for a cooperative agreement with CDC's Division of Diabetes Translation. Again, wants to focus on food insecurity and the burden of diabetes in the community to try to look at gaps on where resources may need to be provided. And so in this use case, data comes from the regional HIE, which has already gotten it from some providers and community-based organizations, along with other providers that aren't part of the regional HIE, other community-based organizations, and some Medicaid data to be able to use that data again, and look at where there may be gaps and programs need to be implemented, and to share back the data with partners in the state. And the third use case really focuses then on data going up to CDC from the program awardees to, again, awardees are encouraged in this story to report and track on individuals at risk for or with diabetes and food insecurity, and then, report some performance measures on that. And then CDC would be really rolling that up and tracking that to look at population trends and identify best practices and share that back with all the program awardees and other partners. So that's very high level. The story's all in the use case package in much more detail. Okay, next slide, please. So at the last meeting, we shared the use case package, and we did get some comments back. So I'm going to walk through those comments and share with you how we have been addressing them. So I believe it was actually during the last use case at the last work group meeting, there was some discussion about adding an assumption that would consider technical standards workflow, and how does that sort of work into things. And so we've added an assumption that indicates that information sources and recipients would be working together to mutually agree upon the technical standards to support the data exchange, that we were not going to be calling those out specifically in the use case, in the use cases and in the use case package. We also had a request for more specificity throughout the story on exactly what data is being sent from the HIE to the county health department. And the examples were, is it line level? Is it fully aggregated? Is it only on individuals that had a screening, or on all individuals? And things of that nature, which are listed here. And, again, as we've said before, while it really is likely that the data needed for a community health needs assessment would be aggregated and de-identified, we have chosen to really avoid specifying the data specifications that would be sent to the regional HIE, because we want to allow flexibility for different situations. And also, we just want to mention, and this will come up a little bit later in the context of the use case package and the story and the use cases, the term aggregated generally is referring to multiple lines of individual level data, whether de-identified or identified. The next comment we got was a request to really define, what do we mean by burden as it relates to areas of highest burden of diabetes? And, we started to use this term after we decided not to use the term prevalence based on the feedback of this work group. And in the context of, again, of this use case package, really the term burden is really meant to be very broad and is meant to be used as a concept and can be defined as we've listed here. Really, again, I'm not going to read it word for word, but and you'll get these the slide deck. But really, it's meant to describe the total cumulative consequences of a defined disease or a range of diseases with respect to disability in the community, and looks at health and social aspects and cost to society, and sort of the gap between an ideal state and what the impact of the disease is on the community. And so we're going to put a footnote in the use case package, or we have put a footnote in to articulate that definition. Next slide. We then also had a request to sort of clarify, how does CDC's 5 priority SDOH areas related to health equity, how are they related to the Gravity SDOH domains? And so we just want to really acknowledge that CDC's 5 priority SDOH areas that are addressing health equity are meant to be, and purposely, very broad in nature. And while there is overlap and some alignment in some areas, food insecurity, housing instability, it is not a one-to-one complete alignment. So we acknowledge that. We also acknowledge that many different organizations really define SDOH domains differently. This is a known problem, and so it makes it a little bit more challenging. And knowing this, we will address the need for better alignment and consistency across all organizations in the final report that EMI will be submitting a closeout report to CDC. We've also added in the use case package in Appendix D, that really is a list of the Gravity SDOH domains, just as a reference point. Next, there was a request to add a general assumption that patient information that is collected is done so in a systematic manner for those that are seeking or visiting clinical or community-based settings. And so we went ahead and added an assumption, which is written here. And it's really to articulate that clinical and community-based settings that they're routinely collecting SDOH information on individuals that they are serving, and that they have a quality assurance and feedback process and workflow to really assure that data collection is occurring and that data is being used. And that was what was intended to be meant by systematic manner. We also had a request to clarify that when we talked about the definition of data repositories, to acknowledge that data repositories can exist at healthcare institutions, and it's not just necessarily public health authorities. So to this point, EMI, we really were in the use case package working to align with definitions that were used in CDC's MedMorph project. And that definition states that data repositories could be operated by public health authorities or research organizations. It doesn't say it's only by them. So, sort of by implication, it does not exclude the fact that other healthcare institutions have data repositories within their own systems, and that they are operating them as well. Next slide. There was also a request to include APHL, which is Association of Public Health Laboratories AIMS platform. The AIMS platform stands for APHL Informatics Messaging Platform, as an example of another trusted intermediary, because it's really a public health trusted intermediary. So we went ahead and sort of used that as another example when we were defining trusted intermediaries in the definitions. And the definition aligns with the MedMorph definition again. And then there was some concern around, under use case 1, the difficulty of adjusting for bias based on gaps in data collection. In previous workgroup feedback, there were comments that community health needs assessment may have biases based on gaps in data collection, and it could end up, reducing the inclusion of specific groups. And so we included an assumption and an activity. And I know that there's some things going on in chat, so I'm just going to run through these and come back and we can answer them once I finished going through these, if that's okay. We also had under use case 1, a request to clarify that the data being sent from FQHCs and CBOs to the regional HIE was identifiable. We had not called that out before, and to include that there was a BAA in place. So because really most commonly FQHCs and CBOs, when they're sending to an HIE, would be sending identifiable data. This is typically what happens in the current state. And it is based off, and the first use case Gravity project use case was around sharing of patient information. We did change that and make that particular part of the use case mentioned that it would be identifiable in that one instance. Next. And so again, as I talked about before, there were a couple of comments around really clarifying what we meant by aggregated, because we kept using it. So there were comments around how were we defining it, and whether CDC was receiving aggregated data or sort of line level data. So again, in the context for this use case package and all that goes with it, we are really defining aggregated most often is referring to multiple lines of individual data. It may be de-identified data, but it's multiple lines of individualized data, or it could be identifiable. Again, we haven't really taken a stance on that, except in the one use case that I mentioned before about going to the HIE from CBOs and FQHCs. And then for use case 2, there was a comment really just wanting to clarify that the diagram in the transaction diagram, that the data from the health system goes to the HIE. So for use case 2, remember that's about data going to the state. So the diagram has data going from the regional HIE and other providers and other clinical providers and other CBOs and Medicaid. And so because the HIE is regional, the HIE has already, in use case 1, we show the data going from providers and CBOs into the HIE. So we feel like that addresses that comment. We just didn't layer all of those transaction diagrams into one long one. We have a general picture at the beginning of the use case that sort of describes the flow. Okay, and the other thing I do want to mention, and then we're going to get to what's in chat, is we did get a couple of comments that came in today, so they're not reflected on these charts because we did not have time to incorporate them. There was a comment about, is there variation between social determinants of health data required by care providers and public health, or do they look at the same data? And our premise in the use case package here has been that, we are again leveraging the clinical data, the individual clinical data around the SDOH data at an individual level, and then using it in aggregate for public health purposes with clinical or other data that is needed. There was also a comment, again, around the aggregated data and definition. So I think we've addressed that through the definition. And then the last comment was, would a county health department be another data source for the state health department? And in response to that, if the county health department is providing direct services and clinical services, then we sort of assumed and sort of counted it under clinical providers. If it's already getting data from clinical and community-based or other providers, and then in some ways it's a trusted intermediary. So we've it's kind of embedded in the other terms that we're using in the workflow of the use cases. So that's the feedback and how we were addressing it. And I'm going to go back up to chat now because I see there's a couple of comments here. So Akaki, you had mentioned, can you clarify aggregate data? It stated multiple lines of individual data. Does that mean individual packaged together or actual aggregate data, like percentages? And so again, I think in this case, we were thinking that it was still individual level, like a lot of, like a bulk of individual level data. And that's mostly how it was being thought of, but it could also in some instances be actual aggregate data, like percentages already rolled up. So I don't know if you want to add anything to that, Akaki?
Yeah, I would just then, unless others agree, I would avoid using aggregated data because if it's multiple lines of individual data, it's not aggregate data. But I don't think that's commonly used that term to describe multiple levels or lines of individual data. So we may want to adjust the terminology.
Okay, thank you for that comment. Other thoughts on that? Okay, Georgia, you were saying that's not what you're seeing in a lot of CDC data sets now. And again, so you're seeing language such as, can you elaborate on your comment, George, if you're willing to?
It's basically agreeing with what Akaki just said.
Okay,
I would stick with the more common definitions of aggregate means it's not the line data. Because I just happen to be doing an inventory of data sets to give guidance to tribes and techs to access. And most commonly, I see things like aggregate and line level data are available. So it's talking about two very different things.
okay, all right, thank you for that.
Amy, I just want to pause here and I
Yep.
want to ask the group, because we've talked about this before in the past. And so is the, so to make it clear to the audience and the reader of this, because I know it sounds like for Akaki and maybe Georgia, they read aggregate and see other things. There's a really broad definition of aggregate, right? And so I'm just trying to get to a place where we can say, so is it aggregate and line level? And would that be really clear to folks?
Well, I would say in the data sets as they're being presented that I'm seeing, it in the definition of what's in the data set, whether the data dictionary or just here are the fields of data that it contains, that defines what may be in line level, or inherently it may define a set that's an aggregate of some type, and you're going to get it in the use case description of what data is included. I don't know if that totally makes sense, but it's in the description of what data is in it, and that's going to vary by data set.
And I see Jim has his hand raised. Jim, would you like to add in?
Yeah, Chantal, I appreciate that. And I guess I would just follow up to George's comments that while I can't comment on what data is getting received at CDC or at the state agency level, I do think we need caution around specifying line data or aggregate data if that implies or assumes a business process, excuse me, around that aggregation that is dependent on what we're proposing as part of the use case in the workflow. I just don't think we want to assume an aggregation occurs or that something is received in the aggregate if it impacts the intended, implementation format.
Thanks, Jim. And yeah, thanks, Georgia. And then Akaki, would you like to, I know Akaki put the wiki definition. Would you like to speak more to this?
No, I just wanted to point out, I just put it Googled. I don't think, I don't know why here, but I don't think there is a usually confusion. Aggregate is never means individual level data, multiple lines of data. I think that's a commonly understood definition, but maybe there are industries where it's interpreted differently, but I've never heard aggregate being used to refer to individual line data. And I think that has implications for how we communicate about those use cases. And I just wanted to underscore that. That's all.
No, thanks, Akaki. Appreciate that. I think we've had just to be frank, I don't think we've talked about this internally with the work group. So, and I think the CDC DDT, when we talked about this, just even from the CDC perspective, and Gia was like, I think from a program perspective, they do want to be able to collect at the individual level. So I think what we're trying to figure out is like, then how would you update that language? So to know that it's like in a desired future state, we don't want to just be saying 38% of people have food insecurity. You know, we want to be able to enable the ecosystem to collect multiple individual lines of data, and maybe that's all and maybe then that's the terminology we use to update. So I'm just trying to, from your like kind of background and definitions or the right terminology to use, what does that like, you know, what is that terminology or phrasing that helps get us to that desired future state?
I'll pose. There are probably people much better qualified than I am to come up with the best way to describe this here.
I see, Art, you had put something in here as well, Art Davidson, about the thought around data aggregated across multiple healthcare providers. Do you have any thoughts on this? I know you had raised, shared some thoughts on this earlier. So based on this conversation and your comment in chat, any thoughts?
Well, basically, I agree with Akaki that, and we should, in response to Shital's question, I would just call it individual level data. That's what it is. So, but I was trying to figure out what you meant by aggregate, and why you were talking about aggregating across multiple institutions, you know, where you would be able to create information for the jurisdiction by having multiple healthcare providers provide their data for the CHNA. So that's what I thought you meant, but I would call it individual level data. That's what it is.
Yeah, that's super helpful.
Yeah, I agree. And then individual data sets, I'm seeing things like contains case data that includes, you know, age, sex, race, ethnicity, and blah, blah, blah. And so they just sort of define what's captured in that particular data.
Yeah, I would agree. It has to be individual line data. And so taking out that aggregate will be helpful, because working for HIEs and health systems that send data, you know, the question is always, is it's identifiable or de-identified data, and is it on the individual patient level? Because oftentimes they're looking for the use case that support individual patient level data, meaning that it's often sent because there's a practice that's going to act on that patient's behalf to sort of do care coordination or something that will for that individual patient. And if not, then you're sending it aggregate data for on the aggregate level, if you're not going to be the individual provider acting to on that patient level data.
So from the community health needs assessment, if there's any county or state folks here, even at the state level, we heard from Gia that, individual line level data, even if, putting aside identified or de-identified was desirable. If we have any state representatives, state health department or county health departments or tribal nations or territories, is there a thought from your perspective about what would be most useful for these use cases if you're trying to identify the areas of high, where there's food and, a lot of food insecurity, and in areas where there's a high burden of individuals at risk for or with diabetes?
This is Georgia. I would say from the tribal perspective, definitely capturing race, ethnicity as a proxy that tribes and tribal epicenters can use is extremely important. Some geographic information, zip code or county or something is also helpful to them in pinpointing data on populations they're interested in. Is another important point. I would throw out for consideration, there's a lot of discussion again around capturing tribal affiliation. but that's not settled. I mean, that would be optimal, but so would a patient ID that followed us around everywhere, which we don't have either.
Okay. All right, so we can go back and revise this based on this conversation, which was very helpful. I don't think there were other comments on chat on any of the other feedback. So I think we can move ahead, and I'm going to turn this over to Sheila.
Yeah, thanks so much, everyone. And thanks, Amy. And so just to keep us moving here, just want to thank the folks that submitted additional persona candidates. And so we briefly touched upon this last week, but for those who might be new or would, just as a quick refresher, we asked folks, to basically submit additional personas that they would like to be included in the use case package. And so you can see the additional personas that we received. And so just grateful for the folks that took the time to put these together, and they'll be included as a part of the appendix to our use case package. And then on the next slide, if we go to the next slide, thank you. Yeah, so again, and I just have the benefit now of saying we'll take the conversation and the discussion related to this terminology, which I think is it's really important to get clear, especially for the folks that, we'll pick up this use case package and hopefully, use it to help accelerate SDOH related information exchange for public health purposes. So we are going to make those, we'll make that update to the use case package related to the term aggregate. And then I just have the benefit of being able to just thank all the folks for your input and for your ongoing feedback and engagement throughout our meetings. Sarah, I saw, did put the link to the use case package in the chat, but we can share it again. And we're just really grateful for sharing your knowledge and experience and time with us. And so we know we wouldn't be here today without everybody's input and engagement. And then I think Gabby is going to take us through just the actual process and how we're going to launch the consensus voting, so you can understand how to vote on that and the next steps in the timeline. And I won't go through the actual document itself because it's a little bit lengthy, but we'll assume that we'll go up and make those changes that we talked about just now on the call today. And then that document will be ready for voting. And so Gabby, I'll give it, we'll pause here first and see if there's any questions. And yes, and feel free to raise your hand or unmute yourself, or you can also put your questions or comments in the chat. And Ravi, thank you so much for saying what Washington is thinking about doing. That's great.
Okay, hearing none, I think we go ahead and get started with an overview of the consensus voting process. Yes, exactly. We covered that right now. Sarah, I'm just looking at the chat really quick without inputs from other PHAs, so public health agencies. So, through this work group, we have over.
Sorry, Gabby, let's just pause. Jim, did you mean on the call right now or any other specific public health authorities from other associations or networks?
Yeah, exactly, Shital, and not on the call presently, but it with other networks and associations. I don't want to complicate this process, but if you were seeking any additional input, I'm more than happy to coordinate something. So. Oh,
thank you so much, Jim. Yeah, Gabby, go ahead. I don't know if you were going to answer that, but I'm happy to take, and Evelyn and Amy too, I'm happy to take a stab at that. But, we would definitely invite folks from those agencies to weigh in, and we would love their input and thoughts. And I know when Gabby goes through the consensus voting process, there is going to be opportunities to still comment or provide input. So that's another way that they can still provide their input as well. So thank you, Jim. I think would love to take you up on that to the extent that folks have time and are available. And Gabby can talk through how to do that. And then Gabby, I just want to also answer Sarah's question in the chat because I'm actually not sure. So Sarah, yeah, go ahead.
Perfect. No, thank you, Sheetal, for answering. And yes, Sarah, you can absolutely update your status, and we're going to show you how to do it. You can do it through just literally emailing myself, and we'll change down the back end, but there's also an option on the SurveyMonkey tool to select the status that you want in terms of your vote. So let me go over that briefly, and then we can definitely take more questions live. And I want to just echo that Kyla, has mentioned that she is happy to follow up with Jim as well on that request to get more public health agencies involved. Wonderful. So recapping our consensus voting process, this is the process where committee members are asked to vote on the documentation and deliverables that we have been developed thus far. This case is specifically with a use case package. We went through this process with the business case back in May. So we're doing the same process for the use case package. Only committee members may vote. Individuals who sign up as other interested parties can only submit comments, but should not be voting. Like their vote doesn't count through the 60% of committee members to achieve consensus. The mechanisms for voting is a SurveyMonkey link that I'm going to preview just in a couple of seconds here. When you receive, and we'll put it in the chat if you don't mind, Sarah, the link, and I'm going to go through it. I believe it's after this slide or so. So you'll get instructions on the SurveyMonkey link as well as the slide deck. So you will be given 1 week to vote. There are 4 voting options. You can vote yes, and it means that a yes vote does not necessarily mean that the deliverable is ideal from the perspective of the committee member, but it's better to move forward than to block the deliverable. Yes with comment, if the consensus process attracts significant comments through yes with comment, we will address those comments in a timely fashion to ensure that we review the comment provided and our steps to addressing it. And the intent is that there will be a future revision for the deliverable based on the comment, depending on the comment. Formal objection. If you vote to formally object a deliverable, you must include a comment indicating what will be the best path to address that objection received. If someone votes formal objection without a comment, that will be considered an abstain vote. And if you are, have press time and cannot vote, you can decline to vote by selecting abstain. So those are the 4 options to voting. In terms of our timeline, so we review the use case package, the proposed package back in July 13, 2 weeks ago. We kindly ask all work group members to please submit feedback on the package by the 18th. We presented on that feedback today, and we are launching for consensus vote. The deadline is for committee members to please submit their vote by August 3rd. We will share the voting result analytics by August 5th, which is a Friday. And, depending on the comments, we'll address them and update the package. And by August 8th, we plan to publish it officially. It will be posted on our Confluence site as a final deliverable and share via Gravity Project social media channels as well. And you're definitely encouraged that once it's posted after August 8th, you're more than welcome to share that with your partners and other interested public health agencies on the final deliverable there, and maybe implement it. Some cases. So I will go over a preview of the survey. I'm going to just hold the screen here for a second, do a quick recap. Again, we really kindly ask you to read the use case package that is labeled for consensus vote. Here is a QR code that you can use right now to see the survey with me if you want to walk through it together. Again, committee members must vote via the form by 12 p.m. 12 p.m. Eastern time. We'll send some reminders as well. And once you vote, you want to make sure you press done. So your vote is recorded. If you are voting yes with comment or formal objection, please submit your comments via the Survey Monkey. For example, you can say yes with comment and say, please change the aggregate definition there, so that is a type of comment that, you can submit. So I'm going to switch screens here for a second to showcase a demo of the Survey Monkey. So I am preview mode. So I hope you can see my screen. So here, as you can see, it is estimated 3 minutes to complete. So I'm just going to walk through it together. You'll see the name of the deliverable, which is the use case package, a description of, what is consensus voting. It provides the opportunity to get input and resolve any issues to finalize this specific deliverable. Voting period opens today and closes on Wednesday, August 3rd, as mentioned. So, just recapping the instructions here. If you have any questions about the membership status, you can contact Sarah and myself. We'll be happy to help you. On the next page, you'll see contact information just to verify who is the voting member. So for test purposes, I'm just going to fill out tests. I'm going to select the state that I'm located in. Again, for test purposes, I am actually in New Jersey, but again, email tests. So here, Sarah, since you have mentioned that you would like to change your status in the chat, we can go ahead and do that change for you and send you confirmation. But here you want to select the membership status, of your choosing. So in this case, commit a member. And we'll cross-check what's selected here with what we have in Confluence. So ensure that those align. From there, we would like to ask you to please select the type of partner that best describes you. In this case, I'm part of the Gravity Project team. So I'm gonna go and find myself there. Gravity Project. If none of this apply to you, there is an other, and you can free text what other is to please specify. Then on the next page, here is the actual vote. So if you haven't had a chance to, download it on the link that we share via the chat, you will find the link to the use case package here as well. So when you click on this, it's going to bring you right into our Confluence site. And this is the package itself. It's about, I believe, 60 pages long. It gives you an overview of the revisions, history, the log, table of contents. And I'm not going through the whole package, but to give you an overview of what it's to review, you get a preface and introduction, how we define each element there, and the use cases themselves are in section 7, broken down into a set of 3 different use cases that we review. There is references and appendices as well. And of course, our list of figures, list of tables, and this is the package. So going back here, I'm gonna, again, this is demo purposes, select yes. If I select yes with comment, just to showcase how to add a comment, you select that, and then here, testing, you can put your comment here. If you want to upload a PDF of a Word document to support your comment, you are welcome to do so by selecting a file. It can be a PDF or a Word doc. In this formats, you upload it from your computer. Gives you right there, and it will be submitted through the survey. So then you press done to ensure that it's recorded, and you should receive a thank you screen at the end with Sarah's and my contact information in case there are any questions. And I'm gonna just make sure that you have this. Perfect. So let me go back here and see if there are any questions. I can put up the QR code, should be available via your phone, your email. That's kind of where we have. So let me pause if there are any questions, concerns about the process of voting. Hearing none, will move us. Okay. Thank you for your patience there. I just want to make sure I don't miss anything in the chat. Thank you, Sarah, for sharing the link. All right, to summarize next steps with everyone. So please cast your vote by Wednesday, August 3rd. You have the link available. The results will be shared via email by August 5th. Just giving us enough time to tally the votes and ensure that everyone has submitted comments. We respond within a timely fashion. And as mentioned, the final use case package, once we reach consensus, which means at least 60% of committee members cast their vote. As of today, we had a membership of 103 committee members, so that equals to 62 votes. That is a number that we are targeting. So you'll receive some reminder emails as we go through the votes and go over our listserv. And the final deliverable, as mentioned, will be published and shared via email by August 8th. So now I'm going to go ahead and do a demo of our Confluence site where you'll be able to see the demo of the workgroup Confluence, and any questions there, please feel free to let us know. I know it's a little bit small. Let me just zoom in here for a little bit. So when you go into our homepage, you're going to find our background information, how this project came about. Again, the listserv that many of you already have signed up. And if you want to change your membership status, the easiest way is to contact me so you don't duplicate your entry there. From there, we highlight the project charter, and then we really have logged all of our calls and materials here on this table. So you get to see here homework after today's call is to vote on the package, and our slide deck, meeting recording, those materials will be featured here within 2 business days. In order to go into, so you can click right here as well to get into the package. When you click on it, downloads it automatically to your computer. For workgroup documents, as you can see here on the project charter, when you go in there, it houses all of our project documents since the beginning, from our initiative 1-pager to the high-level overview of this work that we started specifically with the work group in April, our project charter, as mentioned, the business case that we did reach consensus back in May, the public health use case for voting. This is where it's housed. You'll be able to click on it, download it, read it through here. And then the list of additional personas that Sheetal mentioned is here as well. And one of the earlier topics that we talked about was, how does this initiative relate to other amazing work happening, including Helios and USCDI Plus. So we did provide a summary here for everyone's reference and links to those other initiatives that overlap with this wonderful work. So in a nutshell, let me go into the join the work group. As some of you, are looking, maybe you want to know what kind of membership do I have? It's been a long time since I registered. So the first part of this is, the intake portion of it. And then the second part, it's really showcasing all of our members, and you're able to either filter this or alphabetize this. So if I wanted to look for my name, I can go ahead and type my name, and it tells me that I am a committed member. If you, want to see a colleague, you can add more names. So again, just for test purposes, you get to see that. And then if you, clear it, that goes down, or you can alphabetize it. That's easier. But this is a way to double check what type of membership you have. And if you need to adjust it, please do not hesitate to contact me. We'll be happy to do it. Any questions here? Just checking. Okay. I think it's been pretty clear, I hope. All right. I know we're coming close here, and thank you all for the support. It has been really helpful to just support the entire work group as well as entire team. I'm getting all of our work done. So let me just go ahead and go back to the screen here. And you have our Confluence site there. For contact information, I'll pause here for a moment and see if you have any questions to ask. This is the time post this work group call. Sarah, Kyla, and myself are the point of contacts for this. So we want to make sure that you have our contact information. You should be able to receive emails from us as well. And, just trying to see if there are any comments, questions before we move on. Hearing none, we're gonna move us right along, and I want to make sure we queue up Tim. Can you hear us?
Yes, can you hear me okay?
Yes, we can. Perfect. So let me just spotlight you and I'll hand over the mic.
Thanks, everybody, and thanks so much for the great work that this group is doing and has done over the course of these several weeks. My job is pretty simple right now. It's just to kind of help you think about next steps and where we're moving from this point forward. Next slide. And so I think the first thing to do is to talk about the great body of work that you all have already contributed to, accomplished in the course of these last 8 weeks that you've been working on this, developing the public health business case, thinking through high priority use cases, designing and publishing high priority public health focused use cases for how Gravity's work can be leveraged from clinical care to public health practice. An extraordinary task in that, coming into this work and thinking about how this work got thought out from the very beginning in conversations with Dr. Hacker, Dr. Peter Briss, Jen Wiltz, and others here at our center. It became clear to us that the magnitude and the scope of the challenge that we faced in trying to leverage data for the public health response to SDOH was enormous. And we knew we couldn't get everything done, however, but we knew we had to do something to help set the charge and begin the process of moving us forward. Next slide. And so when you think about then the work that's happening across the landscape, if you will, where does this work fit in and how does this work contribute to that? Part of that conversation can happen in the context of the developing and emerging HHS strategic action plan for health equity and SDOH. This is a slide that we borrowed from their website, talking about how there are a multiplicity of factors that are contributing to our understanding of the social determinants of health ecosystem. I don't know if I've ever seen a full conceptual diagram of all of those elements, both technical, organizational, social, human, etc. But this is a start to help us think through that. And as you look at this diagram, you could see, as they've circled in red, the areas where there might be opportunities for us to think about taking the work and the thought process that you put into this work group and identify opportunities to apply standards in a way that can help advance the state of the state, move the needle, if you will, in operational excellence, and define new ways in which we're partnering and leveraging organizational resources to better address the needs of the population that we serve. Next slide. And as you can see here, diving down a little bit deeper into that strategic action plan that HHS has developed, you can see goal number 1 is actually centered around the idea of building better, robust, more interconnected data to support coordination and evidence-based policymaking. You can see the other goals, as you might expect, are about improving access and adopting a whole government approach to support public-private partnerships, et cetera. The most important thing to take away from this, that this work group can be proud of, is that they've helped to advance the understanding of what the scale and scope of the challenges are and provide leadership with additional insights through your final report, through your published use cases, and other artifacts from this work that can actually be leveraged to help shape the new strategy or the strategy moving forward as we attempt to advance our efforts in this space. Next slide. So with that, a few thoughts then, few takeaways, if you will, of what we anticipate to be some post-work group activities. One, we want to continually support the infrastructure advancements at the state and federal level. There's a lot that you have probably exposed as gaps and opportunities for us to provide change and innovation in support of our health equity and social determinants of health work in this data space. And so exposing those gaps through your gaps analysis were essentially important to our understanding of it, and then helping to think through, what the next evolution of platforms and technology should look like. Next, thinking about how we harmonize efforts across CDC and some of our external partners. We recognize that this is not the only SDOH activity going on either within the CDC or even across the federal government. And so thinking about it from that perspective, that there is a large array of activities, the next thing that we want to take away from this work group and try to leverage is continually find ways to harmonize those efforts, serve as a coalescing agent where possible, and identify opportunities to achieve greater economies of scale, to leverage resources across our many efforts, and to share the incredible human capital that is amassed on this call with many others around the field. Thirdly, we want to identify opportunities to find new funding for expansion of our vision for what a fully functional, fully integrated, fully linked data infrastructure should look like. We recognize that, SDOH and health equity and health disparities in general haven't been fully funded in public health or even in clinical care for a very, very long time. The fact that we just have dealt with certain aspects of equity and vulnerability as exposed through this pandemic only highlights the need for us to continually fight for new resources to be dedicated to this task. And part of the work of this group is to help us build the business case to get those kinds of resources directed at us. Next, we want to find ways to leverage the great work that you heard Nidra Garrett and Akaki talk about with USCDI. Plus, they are doing some tremendous work in helping us to understand the leveraging of standards, partnering with ONC and other organizations. And so we want to continually find ways to link this work on this gravity use case with that work to ensure that we're moving in the right direction. And then finally, we want to build ongoing collaborations with CDC's Data Modernization Initiative. As we're talking about data and standards and interoperability within the context of SDOH here, we can't ignore the fact that CDC and many other federal agencies are undergoing a massive transformation in the way in which we do data, information, knowledge, decision support, et cetera. And so it will be an opportunity for us to leverage in building out the model, if you will, for how we can take what comes out of the advancements that come out of the data modernization to rapidly apply them to the SDOH challenges that we face. Next slide. So with that, I want to extend my gratitude to both the CDC team that you see here, Dr. Jen Wiltz, Dr. Pam Pagano, Dr. Jenna DeCruz, Dr. Kyla Davis, who served as our quarterback on all of this and has been doing a tremendous job in helping to keep this train moving and help lead us to the dynamic products that you see, and of course, Dr. Pradeep Padilla. Next slide. I also want to extend my thanks and gratitude and appreciation to the entire EMI advisors team. Evelyn, you've assembled a tremendous group of experts and tacticians to help us think through this, and we're very pleased with everything that you all have done, and we look forward to building strong collaborations with you moving forward and thinking about how we can take this work to the next phase, if you will, and identify opportunities to have even greater impacts as we move forward. I have one more slide. And that's it. I just want to say thank you for participating in this consensus building process. We really appreciate your time and energy and effort. And trust me when I say that it has not gone unnoticed. Everything that you've done here is working toward creating the argument for how we can partner across this country to make these things happen in an effective way. So thank you so much. Back to you, Gabby.
Thank you all so much. That truly has been a team effort, and without your leadership at CDC, and really without everyone's participation and support through this calls, we have not been able to get where we are today, where we are, wrapping and being able to put forward a very comprehensive use case package. We know we also have our fearless leader on the call. Evelyn, I want to just thank you and see if you have any closing remarks to say. It has been a true honor to support, the use case package, building off the Gravity project and the great work that we're all doing in that specific project.
Yeah, no, thank you, Gabby, and thank you, Tim, for your kind words. This has truly been an honor, and what excites me about not only building a new community, building on the work that we've done, is that we've been able to successfully scale the framework we established under Gravity, which is really about creating trust and open public collaboration, which I think very much resonates with what we do within public health. So it's very population level, community driven, and I think this is just an excellent way to bring everyone together. I also want to acknowledge we've had a lot of learning. So I think by bringing the community together and all those that need and use public health data to improve social care and whole person care, that that we continue doing this moving forward, but learn that there are nuances and that there is more work to do. And as you said, this really highlights where there are opportunities for us to continue advancing the use of data to improve public health overall. So thank you, Gabby, and thank you everyone for your participation.
Absolutely. And I do see that Georgia has shared an event related to a tribal advisory committee. We'll ensure to put that in our follow-up email and you'll get a notification. We're hoping to turn this around by tomorrow, so you're able to have access to the latest package, start the voting process. And again, thank you all. We'll give you a few minutes of your time back, and please stay tuned for the recording and all materials on our Confluence site. You have our contact information. If there are any questions, comments, please feel free to reach out. Thank you all, and that will be concluding our call today.